Welcome to part 2 of our lecture on psychological disorders. In this section, we're going to be talking about diagnosing psychological disorders, and probably a pretty good character. If some of you remember back to Charlie Sheen's rants about 2.5 Men and suing CBS and doing his own little videos there online where he was more or less stoned out of his mind, kind of makes you worry about his psychological stability. Certainly has some distressful moments. I think that we could consider his behavior somewhat deviant. And was it dysfunctional in relationship to his career? Certainly was. Cost him loss of his contract money. So, yep. Anyways, okay. Well, let's take a look then. Okay. When we talk about classifying psychological disorders, we have a manual that we use that is developed by the American Psychiatric Association. And back in the early 1950s, they put this manual together. And at the time, they only had 60 disorders, and now we're at the DSM-4. They start off with the DSM-1. We're at the DSM-4 text revision. And we have some 400 disorders. It's not that we're necessarily getting any sicker in society. It's that we're learning to describe disorders better and learning to differentiate between various disorders. And the 60 we had back in the early 1950s were much more broader and general. And we started to realize is that we needed to break some of these things up and get more specific, is so that we could work better at identifying, how to treat the various disorders. But if you kind of look at the stack here right at the top is the old 1950s manual. Look at it. I mean, it's just, real thin. And then, from there, here we have the DSM-3, DSM-3R, DSM-4, DSM-4-TR. And I mean, we're literally getting up here to, a good 1.5 to 2 inches of paper in one of these things. And, pretty much like a phone book and that. So, very, very detailed explanations, and we'll talk about that as we go through here. When we talk about diagnosing disorders, there are actually 5 axes that psychologists and psychiatrists are asked to diagnose an individual on, either from hospitals or insurance companies or even lawyers in legal cases. Axis 1 up at the top there is basically where we look at clinical syndromes, and there are essentially 16 clinical syndromes such as cognitive, anxiety, and mood. And take a little bit better look at it. Here's from our textbook, is you can see kind of the complete list of the 17. But we come down through there, we have substance abuse related, schizophrenia, mood disorders such as depression, anxiety disorder, phobias, things like that, somatoform, dealing with body. That's where your hyperchondriasis, conversion reactions come in, and eating disorders, sexual disorders, sleep disorders. These are the primary classifications that we go through, and generally we're always going to diagnose somebody on axis 1, and so that's more or less the standard one. Okay. Axis 2 is where we take a look at personality disorders or the potential for mental retardation. And we find that probably pretty much we usually diagnose on axis 1, and it's not uncommon to diagnose under axis 2 as well. And that generally they may have a clinical syndrome, and then they may have a personality disorder that accompanies it. And just to take a look at some of the personality disorders that we have what we refer to as the eccentric personality disorders, and we have a paranoid personality disorder, where an individual generally tends to interpret the actions of others as threatening. They always feel people are watching them, people are looking at them, people are out to get them. And one of the reasons we refer to this as an eccentric personality disorder is a lot of times you see it in eccentric people, or the very rich. And it's interesting that for the very rich, we characterize as eccentric. If they were lower income, we'd say, well, we need to lock them up in a funny farm. And that. So there is a little bit of bias in the system. There's no doubt. A schizoid personality and schizoid typical or typal personality are very similar in that an individual generally is detached from social relationships in the schizoid, and they show a very narrow range of emotion. They're very, they don't get involved in relationships, and their emotional response is very flat. In the schizotypical personality disorder, an individual here is uncomfortable with close relationships. Now, that they may get into relationships, but they're very uncomfortable in it, as opposed to the schizoid, who generally doesn't get involved in social relationships at all, just stays away, doesn't want to have anything to do with them. So those are some forms of personality disorders. Another group that we might call the dramatic ones. There's a lot of flair and a lot of excitement around these things and that. And sometimes the individuals who have these disorders, come off as kind of bigger than life when you have to interact and work with them. The first one is the antisocial personality that we've talked a little bit back in the personality chapter. And here this individual shows a pervasive disregard and violation of the rights of others. As we talked about, is this person's out to get whatever they want. Their id is in domination, and they want, and they know very few, if any, moral boundaries, and they'll run over anybody. They'll do whatever they have to do to satisfy their hedonistic needs. The borderline personality is one of the more difficult personalities, and we're currently involved in writing a DSM-5, which is supposed to come out around May of 2013, but I'm not holding my breath, as the DSM-5 was supposed to have been out around 2010. So they're still soliciting comments on the new manual, and so I'm not quite sure if we'll make that May 2013 deadline. But anyways, in the borderline personality, as an individual shows a generalized pattern of instability in interpersonal relationships, self-image, observable emotions, and significant impulsiveness. They got a little bit of everything going on here. And the borderline personality oftentimes is considered one of the more difficult personality disorders to treat, just because there's so much stuff going on. And, while it's not enough to classify them one way or the other in another disorder, there's just a lot of stuff going on, and it's hard to work a person out of this. The histrionic personality, individual displays excessive emotion, and they have a lot of attention seeking. Nothing is ever just normal for them. They make a mountain out of a molehill every single time they can. Very flamboyant. Everything's always a big deal, whether it's good or it's bad, and that they really overreact and play things up. And the narcissistic personality, down at the last one, have just all these grandiose feelings about themselves. Going back to the picture we had in the personality chapter, the guy looking into the water and seeing his reflection. Well, that's the narcissistic personality type, in the sense that, I can't wait for tomorrow because I get better looking, every day. In Snow White and the Seven Dwarfs, we have, the queen looking into the mirror, mirror, mirror on the wall, who's the fairest of them all. And another example of a good narcissistic personality type, and that. So those are some there. From there, the last set of personality disorders we'll talk about, at least here, is one is the what we call the anxious personality disorders, where they're characterized by having a lot of anxiousness. We have the avoidant personality disorder, and this one here, the individual is basically socially inhibited, feels inadequate, and is oversensitive to criticism. So they avoid everybody. They stay away from people because they just feel like, oh, no, I'm not good at that. I'm not good at interacting with people. And if I'm around them, they're just going to say bad things about me, and I don't want to be with them. The dependent personality is the individual shows extreme need to be taken care of. That basically leads to a lot of fear of separation, passiveness, clingy behavior. A personality that's really characterized by a lot of compliant behavior. I'll be whoever you want me to be. Just love me, just stay with me. And it can really, really get sickening and pretty bizarre. In that sense. The last one, the obsessive compulsive personality disorder, and here the individual is preoccupied with orderliness, perfectionism, and control of at the expense of flexibility, openness, and efficiency. They just have to do this. They have to be perfectly orderly, and everything has to be just right. And once again, talk about a personality that's dominated by the superego. This one's the opposite of the antisocial personality that's dominated by the id. The obsessive compulsive is definitely dominated by the superego, and that you can't have this, you can't have that. You got to have order and perfection. And perfection can be just as irrational a behavior as anything else. I mean, that the strive for excellence is one thing. To strive for perfection just can't be done, and is very unrealistic. So those are personality disorders that we may classify from there. On Axis 3, we look at the general medical condition. We ask questions about, how are they doing? Do they have diabetes? Do they have hypertension? Do they have arthritis? Interestingly, some of these disorders can actually influence changes in personality, as well as the medication that they may take for those types of disorders may influence their behavior or mood. Back in when the birth control first came out, one developed by a corporation called Orthonovum, it was a very heavy estrogen-based pill. It was very effective as a contraceptive device. However, the thing is that the estrogen produced tremendous mood swings in women. And we had a lot of women showing up in psychologist's office, psychiatrist's office, talking about, gosh, I got all these mood swings that are so uncharacteristic of me. I can't seem to get, the stay in control. Sometimes I just want to break down and cry and, go to bed and things like that. And basically the solution to this was sending them back to their OBGYN and having them sit down and talk about this change in behavior and changing their medication over to a progesterone-based pill at the time, which generally within about 3 to 4 weeks, you would see all that adversive moodiness that they had prior begin to disappear and go back to having normal mood states. From there, we move to Axis 4. And here we look at for any psychosocial or environmental problems, school problems, housing problems, things like that. You're looking at mental retardation. Mental retardation sometimes can be based on general medical conditions, such as maybe a child has very poor hearing and just doesn't respond, and people think that the kid is a little bit slow. There can be environmental factors where maybe they haven't received the release stimulation. They're kind of delayed in their maturation and things like that because they didn't get good intellectual stimulation. So these axes are very important and kind of help filling in the information to support either Axis 1 or Axis 2. The last axis that we have is the newest axis that came in actually in 1980 with the revision to the DSM-4, and it's related to the global assessment of an individual's functioning. And here what we do is we take a look at it we talk about everything that's kind of wrong in 1, 2, 3, and 4. Here in 5, we actually come back and say, well, gee, with all that stuff going on, where do they stand today? Can they, do they need to be in therapy, not in therapy? Do they need to be hospitalized or whatever? And here's the global assessment of functioning, and kind of at the top there where you see the green numbers and it says no therapy warranted. In any of those categories up there, we would say a person really doesn't need therapy. They're going through, kind of the adjustment problems that we all go through, and there's nothing really extremely deviant or dysfunctional about their behavior. When we move into the L zone in the middle, between about 31 and 70, this is the area where we start to look at maybe outpatient therapy would be warranted. And as you start to look at it, we're starting to get into some things that are leading to maybe stress and dysfunctional behavior, and not allowing them to live, kind of a healthy, normal life. When we drop down into the red zone, well, now we got them having delusions or hallucinations. They got the imaginary buddy or partner out there with them. And definitely we're starting to see a loss of dealing with reality. And generally this is when we would start to look, if a person's down in this particular area, is thinking about maybe it's time to inpatient them. So you see down in the 10 through 0.01, when we get down there where maybe somebody has suicidal ideation, or they have indicated that yes, they've tried to commit suicide recently, they're still considering it, and that's a no-brainer when we automatically hospitalize, basically, to protect the individual. I, as a psychologist and psychiatrist and medical doctors, we have what is known as the duty to protect and the duty to warn, and our first obligation is to protect the lives of our clients. And we also have a duty to warn. If they're not going to take action, is to let other people know, particularly if they can be dangerous to other people. We have the duty to warn them and contact the authorities. So, okay. From there, then, we've been talking about the DSM. We've talked about the axes along which we describe our personality and diagnose it. The DSM, though, is kind of like that manual. Is, what is depression, and how do you identify depression from deep sadness? Well, I would turn to the DSM and look at the various disorders, and it's going to tell me basically, this is depression if they have this, heavy, persistent sadness. And pretty much when we diagnose things here, we're looking at it being persistent. We all have bad hair days where we all go through bummed out, but it doesn't mean that we suffer from a psychological disorder unless it occurs on a relatively repetitive behavior basis. And that's where we talk about it being persistent. It comes, it goes, it comes and goes, it comes and goes, but it always comes back, and there's definitely a pattern to it. That's when we start to look at it and say, maybe there's a psychological disorder functioning here. But the DSM is kind of our guide, and that it'll tell us, to say, well, this had to occur, 6 times this month, or it had to occur, 3 times this week, and starting to look at the frequency. And that's why it's called the diagnostic and statistical manuals, because a lot of statistics are brought in, looking at the frequencies of behaviors, trying to make it as empirical as we possibly can. Okay. So the disorders that are outlined in the DSM-4 are relatively reliable. When professionals sit down and diagnose the same individual, we generally come up with a relatively similar diagnosis because of the exacting definitions and criteria that are used to diagnose the various syndromes and personality disorders. The other side of this is that people criticize the DSM for putting any kind of behavior within the compass of psychiatry. I mean, almost anything you do can be considered deviant, stressful, or dysfunctional. And, people say, well, there's just too much in here that, almost anything you could do could be interpreted under one of these 400 disorders, okay, as being dysfunctional behavior. And they do have a point, but, that's where, you as a psychologist or psychiatrist is doing the diagnosis, have to use some good common sense, okay? Critics of go further and talk about the aspect of labeling, when we label people. And they argue that when we label an individual, we give them this diagnosis, is that we stigmatize that individual. Somebody gets labeled as depressed. And, from then on, everybody talks about, oh, so-and-so's depressed. And, they suffer from depression. And what does that label do? And all of a sudden we start, responding to them differently. Just looking at the picture here, we see a group of, dated, handsome men, sitting here with their ball caps on and mustaches. And then, it's like, wow, look at this group here. And then all of a sudden you see asylum written across it. And what's your assumption? They're the inmates, aren't they? And rather than looking at the people standing in the back rows as maybe being the owners or the managers of this ball club, now, it's like, well, they must be the shrinks and that. And this labeling can go through. And it's one of the things that we have to be relatively careful of. I know in my own personal practice, I try to use minimum amount of labeling. I do have to diagnose, but I try to play the diagnosis down and kind of use the least severe label I can use that still will allow the person to have insurance benefits and that. So if you dumb it down too far, the insurance company is going to say, oh, this is just a regular, problem coping or adjusting with life, and they won't pay. Okay, so labels in some cases may be helpful for healthcare professionals when we're communicating with one another and trying to establish therapeutic interventions. And I mean, the labels are good because, I say, well, gee, I'm dealing with a depressed patient. What do you recommend here? Or I'm dealing with a transvestic individual, or I'm dealing with a schizophrenic, or I'm dealing with a person who's a hypochondriac, and all of a sudden people say, oh, I immediately identify, well, gee, this is what this person's like, these are the symptoms, and here's the ways that you might go about treating them. So it gives us a good common vernacular. Additionally, labeling the insanity label oftentimes raises a lot of moral and ethical questions about how society should treat people. If a person is insane, can we put them on trial? Can we subject them to the death penalty? Theodore Kaczynski here is an individual who pleaded not guilty due to insanity, and he's better known as the Unabomber, and he had a thing for blowing up United Airlines planes, and he killed several hundred people. And everybody want to see this guy, more or less burned at the stake for what he did. Yet, when he completed not guilty due to insanity, could we then, in fact, if he, was insane, try him and convict him and send him to let's say the gas chamber or the electric chair, whatever they have. The thing is in order to render a diagnosis of insanity, one of the things we look at is, can the person distinguish between what is right or wrong? And interestingly enough, after we arrested Theodore Kaczynski, there was no admission of guilt. He did not distinguish that he did anything wrong. Did he feel any remorse, which is another category that we look at? No. He had no remorse. He didn't see any reason to be remorseful. And he just did what he did. And, you start to say, well, this isn't normal for human beings, which is true. It definitely is deviant. It's away from the norm. And as a result, he was found guilty of the crimes, but sent to a state mental health institution where he'll probably remain, for years to come, but he'll receive treatment for his disorder, and at any time, at some time in the future, if they should determine that he's normal now, he could be released from prison. Okay, so Timothy McVeigh and the Oklahoma City thing, the same thing. Couldn't distinguish between what was right and wrong. Thought that what he was doing was perfectly right. Couldn't see anything wrong about it, and really didn't feel a lot of remorse. So those are issues. Okay, that wraps up part 2, and we will move on into part 3 in our next segment and talk about anxiety disorders.